So before we dive into the revascularization of acute mesenteric ischemia, we have to separate this disease in three forms. The first one, the atherosclerotic one, where we have a calcified or non-calcified atheroma plaques. The second one, which is the embolic type, where you have a clot lodged into the superior mesenteric artery. And finally, the dissection. And I'm not talking about an extension to the superior mesenteric artery of an aortic dissection. I'm talking about an isolated, spontaneous superior mesenteric artery dissection, which occurs in less than 5% of the cases. So those three forms can be analyzed with the famous movie by Sergio Leone, The Good, the Bad, and the Ugly. So let's begin with the first one, the plaque, the atherosclerotic plaque, which can be calcified or not calcified, and involve mostly the proximal part of the superior mesenteric artery. It would lead to a complete occlusion of the artery, but not always. Sometimes a significant stenosis is sufficient to cause an acute mesenteric ischemia. To treat those lesions, we use stents. And since the result of the Kobayashi trial, we recommend to use covered one over bare metal stent, even if the trial was designed for chronic mesenteric ischemia, because it's the same lesion. So we try to center our stent to the most predominant lesion. For that, we have to retract a little bit the stent into the aorta, also the sheath to inflate accurately the balloon expandable stent on the lesion. Brachial access tend to be less and less utilized, as my colleagues say, because now with the use of steerable sheath, crossing proximal lesion has become significantly easier because of the enhanced push force they provide. You can look at the bottom image. You can see our sheath has like 180-degree angle. That's very easy to cross those lesions. Be cautious if you use a balloon expandable stent, because we have some cases of balloon retraction or even stent balloon dislodgement if you don't use or don't perform a pre-dilatation. So the plaque is really the good, because if you're a little bit experienced, those procedures can last less than 1 hour in local anesthesia. Now we're going to talk about the clot. So you will have an hypoattenuating clot that can ramify into the colic or the jejunal artery. Sometimes the clot is very distal, and to treat those lesions, you have to perform a thrombectomy. You have to remove the thrombus from the superior mesenteric artery. We tend to limit or attempt to free pass as the neurointerventional radiologists do, because you will face, if you keep pursuing, you will face some dissection or spasms that can worsen your angiogram and your success. I don't have any recommendation whether to use a manual thrombectomy with the traditional 60mm vacuum syringe or to use mechanical device, such as the vacuum thrombus aspiration, stent retriever, or thrombus excision. Those devices are expensive, and none have shown their superiority over the traditional manual technique. So the clot can be regarded as the bad, because even if you are experienced, you have a procedure that lasts for 2 hours in general anesthesia, the rate of failure will be approximately from 25–30%, meaning that you will have to use intra-arterial thrombolysis. Finally, the intima lesion, where you have a mural hematoma that can lead to a complete obstruction of the SMA. The main thing you have to remember is the revascularization is only indicated if there is an acute mesenteric ischemia, and AMI occurs in less than 30% of those dissections. And don't confuse pain, abdominal pain, with acute mesenteric ischemia, because the mural hematoma itself will cause pain. So to treat those lesions, we tend to use intra-arterial thrombolysis. We put the multiple pore catheter into the false lumen of the superior mesenteric artery, and we instillate alteplase for 12 hours, 24 hours, sometimes 36 hours. And so this is still an experimental technique. We publish a case study about it, but the alternative is the open repair of the SMA. So the intima is really the ugly, because it's ugly, but its IMI will occur in a very few proportion of the cases. So now that you manage to recanalize your artery, your patient in the following hours, maybe the next day, will experience an abdominal pain, maybe with some GI bleeding and with an inflammatory syndrome. The question you have to ask yourself, is there a persistent ischemia? So the patient underwent a contrast-resonance CT. You see that your SMA is well recanalized, but you have your bowel, you have a thickening of the bowel with a mucosal hyperenhancement, submucosal edema with a parietal thickening, ascites, and thus CT pattern is consistent with a reperfusion injury. And this syndrome has to be treated conservatively. Do not operate on this patient because the bowel is viable. So, despite guidelines, endovascular revascularization is performed in less than 25% of the case at a worldwide scale. Persistent viable bowel is a prerequisite to perform endovascular revascularization. And we recently published a paper that shows that in selected patients, the morbidity is low. In patients with a CRP level below 100 and a persistent enhancement of the bowel, more than 85% of the patient will not need a resection at all. And I will finish with this case where you can see evidence of a right colonic transmural ischemia. The patient is in septic shock with no higher solution of vascular surgery. So the emergency treatment in this case are the resection. The patient has to be resected on site. Do not lose precious time to transfer the patient to a primary care center. Thank you.